Imagine your heart, the most vital muscle, tirelessly beating, keeping you alive. But what if, silently, sort of beneath the surface of everyday life, it began to change, to weaken, perhaps even putting you at risk without any obvious alarm bells? It's a world most people don't fully understand about heart disease. Today, we're pulling back the curtain on a set of conditions that can profoundly impact the heart's function, the cardiomyopathies. These aren't your typical heart attacks or valve issues.
Yeah,
They're often quiet, insidious, and actually surprisingly diverse in how they show up.
that's right. They can be real chameleons.
Maybe you or someone you know has been diagnosed with heart failure without a clear cause, leaving you with just more questions than answers. Or perhaps you've heard a story about a sudden cardiac event that just baffled you and you wondered, how could that even happen? Well, we're here to unpack exactly what these conditions are, how they manifest, and crucially, what it means for someone living with them, and importantly for their families too. And here's where it gets really interesting. We'll reveal how things like stress, alcohol, or even pregnancy can subtly reshape the heart, and how understanding these connections is absolutely vital for prevention and treatment.
Absolutely crucial.
Okay, let's unpack this. Our deep dive today is into the fascinating, complex, and often overlooked world of cardiomyopathies. We've compiled a stack of material that hopefully brings some clarity to these conditions, from their fundamental definitions right through to their genetic secrets and the most effective ways they're managed.
Yeah, there's a lot to cover.
We'll explore conditions like dilated cardiomyopathy, arrhythmogenic right, ventricular cardiomyopathy, Takotsubo, also called broken heart syndrome.
That's the one people often hear about.
Right. Exactly. And even those induced by excessive alcohol or rapid heart rates. Each one offers really unique insights into the heart's incredible adaptability and, unfortunately, its vulnerability too. Our mission today is to transform this complex medical information into clear, actionable knowledge for you, complete with surprising facts and maybe more than a few aha moments, all without the information overload.
We'll try our best.
Before we dive in, we really want to extend a special thanks to London Heartbeat ZZ Academy, UK. Their invaluable educational support makes deep dives like this possible, and their commitment to sharing knowledge is truly inspiring.
You here?
And for those of you hungry for more in-depth learning, we highly recommend exploring the Academy. They offer over 150 popular courses across a really wide range of subjects. You can find free regular updates and ensure you don't miss future amazing discussions by subscribing to their social media channels. That's Facebook, Instagram, and YouTube.
Great resources.
And for early access to educational videos, plus opportunities for personal chats and guidance sessions, you might consider subscribing to their higher level of YouTube membership. It's a fantastic resource for continuous learning.
Definitely worth checking out.
Okay, let's illustrate the real-world impact of these conditions right away. Imagine Sarah. She's seemingly healthy, 30 years old, out jogging one morning when she suddenly collapses.
Oh, wow.
Thankfully, quick action, she was resuscitated. But it was, as you can imagine, a terrifying experience. After extensive tests, ECG, echo, eventually genetic screening, she was diagnosed with familial dilated cardiomyopathy, linked to a specific gene mutation. Her family, understandably, shaken. So what happened next for them? And how did this understanding actually make a difference? We'll come back to Sarah's story and its ripple effects a bit later in our deep dive. So let's start with dilated cardiomyopathy, or DCM. When we talk about heart conditions, people often think of blockages or, heart attacks. How is DCM different? What exactly defines this condition?
Well, what's fascinating here and really key is that DCM is a primary problem with the heart muscle itself. Unlike a heart attack where blood flow is blocked, or maybe a valve issue where a valve is leaky or tight, DCM is characterized by the main pumping chamber of the heart, the left ventricle.
The powerhouse.
Exactly, the powerhouse. It becomes enlarged or dilated, and coupled with that, it struggles to pump blood effectively. We call this systolic dysfunction. Think of it like a balloon that's been stretched too thin. It's bigger, yes, but it's lost its ability to snap back with force. It's become floppy in a way.
That's a great analogy, really clear. So is there just one type of DCM, or does it show up in different ways? Can it be caused by different things?
Indeed. We primarily categorize DCM based on its cause, or sometimes lack thereof. There's non-ischemic DCM, meaning the cause isn't related to blocked arteries. That's a big category. Then there's genetic DCM, where inheriting factors are clearly at play, often running in families. And finally, there's idiopathic DCM, which is a bit of a catch-all term for cases where even after a really extensive evaluation, we can't find an obvious cause.
Okay.
And if it clearly runs in a family, we specifically refer to it as familial DCM.
Got it. Beyond that initial definition, what kind of history might a clinician look for to suspect DCM? What are the subtle signs or risk factors a patient might not even realize are important?
Yeah, this raises an important question. How does it typically prevent itself? The symptoms are usually quite insidious and long-standing, meaning they develop slowly, often over a long period. People might notice, increasing fatigue, maybe getting breathless during activity they used to handle fine, perhaps some swelling in their legs.
Things you might ignore for a while.
Exactly. And a key clue for clinicians is often the absence of chest pain. Chest pain typically points more strongly towards coronary artery disease problems with the heart's own blood vessels. However, if chest pain is present, it doesn't rule out DCM, of course, but it does warrant suspicion for coexisting coronary artery disease. You have to
Yeah.
look at the whole picture.
Right.
Beyond the symptoms themselves, a detailed history of certain exposures is vital. For example, significant alcohol consumption is a known risk factor we'll talk more about later. Also, the use of certain drugs, particularly some chemotherapy agents like anthracyclines, which are powerful cancer medicines, can damage the heart.
Right.
And even some other medications like hydroxychloroquine or HCQ. Also, a history of neuromuscular disorders, conditions affecting nerves and muscles can be linked. And critically, a family history of sudden cardiac death or SCD, or even someone in the family needing an implantable cardioverter defibrillator, an ICD. These are major red flags.
Wow, so lots of potential clues in the background.
Absolutely. These elements of a patient's past provide crucial puzzle pieces for diagnosis.
So what can a doctor actually see or feel during a physical examination that might point towards DCM?
Well, during an exam, the findings often reflect the heart's struggle to pump efficiently. This can mean signs of what we call biventricular dysfunction, where both the left and the right sides of the heart are affected. Although I should say, DCM very commonly presents with predominant involvement of just the left ventricle.
Yeah.
A doctor might observe signs of fluid overload, like that swelling in the ankles or legs we mentioned, or they might listen for crackling sounds in the lungs, called rales, which indicate fluid buildup.
Mm-hmm.
These are all clues that the heart isn't effectively moving blood forward.
Okay. And the ECG, that classic zigzag tracing we all recognize. I must tell a story here about the heart's electrical activity, right? What are the typical patterns you might see that suggest DCM?
Definitely. The ECG can reveal several indicators that help guide us. You might see signs of left ventricular hypertrophy, which basically means the heart muscle is working so hard it's trying to thicken. Although, paradoxically, in DCM, the overall wall thickness often remains normal, but the total muscle mass increases because the chamber is stretching out.
Ah, interesting distinction.
Yeah. Nonspecific STT wave changes are common, indicating just general electrical abnormalities. As are bundle branch blocks, which are delays in the heart's electrical conduction system. And this is fascinating because conduction system disease specifically has particular genetic associations, such as with the LMNA gene. It highlights how these electrical problems can be rooted in the very genetic makeup of the heart muscle itself.
Wow.
Now, while pathologic Q waves, which suggest dead heart tissue, maybe from a past heart attack, can be present, their presence should always prompt careful consideration of advanced atherosclerotic heart disease because that's a more common cause of those Q waves.
Got it. Don't jump to conclusions.
Yeah. Exactly. And in very advanced cases where there's extensive fibrosis, essentially, scar tissue forming throughout the heart muscle, you might see low voltage limb leads on the ECG. This reflects the widespread damage and reduced electrical activity.
Okay. Echocardiography, the ultrasound of the heart, that seems like it would be absolutely key here, giving doctors a real-time visual. What can it show us about DCM?
Echo provides truly critical visual evidence. It's often the test that really confirms the diagnosis. It will directly confirm that left ventricular systolic dysfunction, showing that the main pumping chamber is weak. And in at least 1/3 of cases, it will also show biventricular dysfunction, meaning both sides are struggling.
Right.
Interestingly, as I mentioned, the left ventricular wall thickness is almost always within the normal range, yet the total left ventricular mass, the overall amount of muscle, is invariably increased. This reflects that significant dilation of the chamber, stretching the existing muscle rather than thickening it in that unhealthy, concentrated way you see in other conditions, like hypertrophic cardiomyopathy. Most commonly, there's what we call global LV hypokinesis, meaning the entire left ventricle contracts weakly. However, you can also see regional wall motion abnormalities, where specific parts of the wall move abnormally. For instance, septal dyskinesis, Abnormal movement of the wall between the ventricles is pretty common in people who also have a left bundle branch block on their ECG.
Uh,
If there's disproportionate thinning of a wall segment that's moving poorly, that should raise the possibility of coronary artery disease again, as blockages often cause localized damage and thinning. Another frequent finding is mitral and tricuspid regurgitation. That's where the valves don't close properly, often because the heart chambers they sit in are so enlarged and distorted. This leads to significant backflow of blood, which can sometimes be quite severe and add to the heart's workload.
Given the mention of potentially coexisting coronary artery disease, is a coronary angiogram, that test to look for blocked arteries, always necessary for a DCM diagnosis?
Well, coronary angiography should certainly be considered in all patients who have risk factors for coronary artery disease, or CAD. Things like being a cigarette smoker, having a prominent family history of early onset CAD, or familial hypercholesterolemia. Age also plays a role. It's generally recommended for males over 40 and females over 45.
Yeah.
If obstructive coronary lesions, meaning significant blockages, are found, their functional significance has to be carefully evaluated. We need to determine if they are the true cause of the heart's pumping dysfunction or if they're just incidental findings, because simply having some plaque doesn't automatically mean it's causing this particular problem.
You need to connect the dots properly.
Exactly. It's about ensuring we don't miss the real culprit behind the DCM.
And what about cardiac magnetic resonance imaging, or CMR? That sophisticated MRI scan for the heart? How does that contribute to understanding DCM?
CMR offers unique and incredibly detailed insights. It's a really powerful tool, a pattern of what we call non-transmural delayed gadolinium enhancement, which basically means finding scar tissue that's not related to a typical heart attack pattern, and it's in a distribution that doesn't follow a specific coronary artery territory within that dilated left ventricle. Well, that pattern strongly suggests a non-ischemic cause for the DCM.
So the pattern of scarring tells a story.
Precisely. It indicates the damage isn't due to a blocked artery, but likely a problem with the muscle itself. Certain conditions, like sarcoidosis, which is an inflammatory disease, can even have a very typical appearance on CMR, making it invaluable for differentiating the underlying causes of DCM. It's also incredibly useful for evaluating the extent of myocardial fibrosis or scarring in DCM. Knowing how much scar tissue there is can help predict prognosis and potentially guide treatment strategies.
This takes us into even deeper diagnostics like a heart muscle biopsy or genetic testing. When are these considered in the search for answers?
Right. So when no obvious cause for DCM can be found, even after a really comprehensive clinical evaluation, these patients often get assigned a diagnosis of idiopathic DCM.
The unknown category.
The unknown category. But here's where genetics plays such a crucial role. Familial DCM, which we find in 10% to 20% or maybe even more cases when we screen families, is now definitively known to have a genetic basis.
Yeah.
It points to an inherited predisposition, like a silent genetic blueprint for heart weakness.
Right.
And what's fascinating here is that truncating variants, a specific type of genetic mutation that basically cuts a protein short in the giant scaffolding protein called titin, TTN, have been identified as the most common genetic association.
Right.
Yes, titin. It accounts for 10% to 20% of DCM cases, depending on the study group. This protein, titin, is absolutely massive and critical for the structure and elasticity of muscle, including heart muscle. So defects here can have really widespread effects on the heart's ability to contract and relax effectively. And even though familial DCM is clearly genetic, whether sporadic DCM, where there's no apparent family history, also has an underlying genetic basis, is still an area of active research. It's important to remember, too, that patients with DCM typically have an asymptomatic phase, sometimes for many years, before they develop symptomatic heart failure or an arrhythmia or maybe an embolic event. This really highlights the insidious nature of the condition and the huge importance of early detection if we can manage it.
So the genetic aspect is clearly significant. How many genes are we talking about here that can cause DCM, and how are these conditions typically inherited within a family?
The pathogenesis, or the underlying mechanism of DCM, is incredibly complex and diverse. More than 30 different genes have been identified as causing DCM, a phenomenon we call locus heterogeneity.
Locus heterogeneity.
Yeah, it just means many different genetic recipes or locations on our chromosomes can lead to the same heart condition. This makes diagnosis more challenging than if only one gene were involved. The diverse subcellular locations of these implicated genes, meaning where in the cell these proteins normally do their jobs, actually helps differentiate DCM from another type of cardiomyopathy called hypertrophic cardiomyopathy, or HCM. In HCM, the problem is usually more focused on the heart's contractile proteins themselves.
Okay.
Now, inheritance patterns. Most cases of familial DCM are transmitted via autosomal dominant inheritance. This is a key pattern to understand, meaning if a parent carries the mutation, each of their children has a 50% chance of inheriting that same genetic variant.
Okay, a coin toss for each child.
Pretty much. Autosomal recessive disease, where a child needs to inherit 2 copies of the faulty gene, one from each parent, has been reported, but it's less common. It's seen more often in families where parents might be closely related. We also see X-linked DCM, resulting from rare variants in the gene responsible for Duchenne muscular dystrophy, or DMD. What's crucial here is that this has been observed even in patients without any obvious signs of muscular dystrophy. It can affect both males and carrier females, which kind of expands the clinical spectrum of what we thought that gene could do.
Right.
And finally, mitochondrial DCM, related to the energy-producing parts of the cell, the mitochondria, has also been reported, especially in the context of broader syndromic diseases where other organ systems are affected as well.
That's quite a genetic landscape. It sounds really complex. Given this complexity, what's the recommended approach when someone is newly diagnosed with cardiomyopathy? Do they just jump straight to genetic testing?
That's a great question. With a new cardiomyopathy diagnosis, a thorough genetic evaluation should be initiated. Now, it's important to understand that a genetic evaluation precedes genetic testing. Sometimes, after a really thorough clinical assessment and family history, testing might not even be required if the cause seems clear, maybe due to a known toxin exposure, for example.
Okay.
However, genetic testing is almost always recommended as a crucial component of a comprehensive genetic evaluation to thoroughly investigate those potential inherited causes we just talked about. And the concept of a genetics-first approach, rather than waiting for the full phenotype-first clinical picture to emerge, well, that's proving very helpful.
Genetics first.
Yeah, meaning looking for the genetic cause even before the disease fully manifests clinically, or maybe when it's very mild. This is especially important in potentially preventing devastating events like sudden cardiac death. It raises that critical question. If we can pinpoint the genetics early, can we actually get ahead of the disease?
Proactive approach.
Exactly. It emphasizes looking for that genetic predisposition even before the full clinical picture is obvious, allowing for early intervention or closer monitoring.
That brings us to family screening then. How important is that for relatives of someone diagnosed with familial DCM?
Oh, it's absolutely essential. Cardiovascular clinical screening of all first-degree relatives, that's parents, siblings, and children, is critical. This minimum screening should include detailed history taking, a physical examination, an ECG, and an echocardiogram.
The basic workup.
Yes, and if DCM is identified in one of those relatives, then screening of that relative's first-degree relatives is indicated. This is known as stepwise or cascade clinical screening. It creates a ripple effect of proactive health management throughout the family tree.
Makes sense.
And the rationale is crystal clear. Early drug intervention, for example, with an ACE inhibitor or a beta blocker, may actually delay or even prevent the progression of the disease in these at-risk family members before they become symptomatic.
Wow, that's powerful.
It is. It's a powerful, potentially life-changing reason to pursue these genetic insights and family screenings.
So what does the actual genetic testing involve these days? And how important is counseling throughout this entire process? It sounds like it could bring up a lot for families.
Absolutely. Genetic testing is now commonly conducted using next-generation sequencing, often looking at panels of genes. These panels can range from, say, 50 to 80 genes, or sometimes even more, all known to be associated with cardiomyopathies.
Quite comprehensive.
Very comprehensive. It allows for a broad and efficient search for known genetic variants linked to these conditions. In the United States, most insurers typically cover genetic testing when it's accompanied by appropriate genetic counseling and the proper diagnosis coding, which really underscores the medical community's recognition of its importance.
And the counseling part.
Genetic testing should always be conducted within the context of genetic counseling. Always. The goals of this counseling are crucial. First, to review the genetic inheritance patterns, like that autosomal dominant pattern we discussed, and the clinically relevant facts regarding idiopathic and familial DCM. Second, to ensure a comprehensive family history has been completed and properly interpreted, including identifying all the relatives who might be at risk. This really personalizes the genetic information for the patient and their family. Counseling is also essential for providing clear information about the risks, the benefits, and importantly, the limitations of clinical genetic testing. This includes discussing the possible consequences of uncertain or inconclusive results. Sometimes we find variants we just don't know the significance of yet.
Right, a variant of uncertain significance.
Exactly. Or even the discovery of a heritable disease and its potential psychological implications. This can be significant for individuals and families, so preparing them for the various outcomes is vital. These processes are time-consuming and require specialized knowledge, which is why guidelines generally suggest referring patients to individuals or centers with significant experience in genetic cardiology.
That makes a lot of sense. What happens after the test results come in? Is counseling still necessary even if no specific genetic variant is found?
Yes, post-test counseling is indicated regardless of whether a pathogenic or likely pathogenic variant is found in a relevant cardiomyopathy gene. And that's because the sensitivity of genetic testing varies, as we touched on. For DCM, it ranges from maybe 20% to 25%.
So you might miss it.
You might miss it. It means we don't always find the genetic cause even if it's there. This highlights the limitations of our current technology. So a negative test doesn't necessarily mean there's no genetic component, just that we haven't found it yet. For arrhythmogenic, ventricular cardiomyopathy, or ARVC, the sensitivity is higher, maybe 25% to 50%. And for restrictive cardiomyopathy, or RCM, it's often lower, maybe only 10%.
Okay.
So if testing doesn't return a pathogenic or likely pathogenic variant, at-risk first-degree family members are still counseled to continue with clinical surveillance, the ECGs and echoes, because the genetic cause might simply be unknown or undetectable by current methods. However, if a pathogenic or likely pathogenic variant is identified in the person who was first tested, we call them the proban, then testing any other family members who already show evidence of cardiomyopathy helps build the case, strengthens the evidence that the identified variant is indeed relevant for the disease in that family. And for other at-risk family members who don't yet show symptoms, testing can really aid in their risk stratification, allowing for more proactive management and potentially those preventative therapies we mentioned earlier, like starting medications early.
Okay. So once diagnosed and all this genetic information is hopefully understood, how is DCM typically treated? What are the goals?
The therapy for DCM is remarkably similar to the general treatment strategies used for all types of heart failure, with a reduced ejection fraction, meaning a weakened pump. This typically involves a combination of medications. Key players are drugs aimed at improving the heart's pumping function and reducing strain, like ACE inhibitors, ARBs, angiotensin receptor blockers, ARNIs, angiotensin receptor neprilysin inhibitors, beta blockers, and MRAs, mineralocorticoid receptor antagonists.
The standard pillars of heart failure therapy.
Exactly, plus diuretics to manage symptoms like fluid retention and swelling. The goal is really to stabilize the condition, prevent it from getting worse, improve the person's quality of life, reduce hospitalizations, and in some cases, we can actually see improvement in heart function over time with these therapies.
Let's bring this to life again with Sarah's story, the 30-year-old who collapsed while jogging. She was diagnosed with familial DCM linked to a specific gene mutation. Her family was shaken. So what happened next for them? How did this knowledge actually help?
Right. Sarah's story is a classic, though obviously frightening, scenario that really highlights the critical role of genetics. Following Sarah's diagnosis, her first-degree relatives, her parents, her two siblings, and eventually, when they were old enough, her young children underwent that cascade clinical screening we talked about.
Okay.
And here's the key part. Her older brother, Mark, who had always been completely asymptomatic, no symptoms at all, was found to have early signs of left ventricular dysfunction on his echo. Just subtle changes, but they were there.
What?
And genetic testing confirmed he carried the same TTN gene variant as Sarah. Her parents and younger sister tested negative for that specific variant and showed no signs of DCM on their screening, though they would wisely continue general cardiac surveillance just in case.
So what was the practical application of this knowledge for Mark, her brother?
For Mark, this early diagnosis, picked up only because of the family screening triggered by Sarah's event, meant he could begin proactive management before he ever developed symptoms. He was immediately started on an ACE inhibitor and a beta blocker, those drugs known to potentially delay or even prevent disease progression in people with early signs of DCM or genetic risk.
So it gave him a head start.
A crucial head start. This genetic discovery didn't just explain Sarah's sudden cardiac arrest, it gave her brother the opportunity to intervene early, potentially saving him from developing developing severe heart failure or experiencing a similar sudden cardiac event years down the line. It literally transformed an unknown family risk into a clear pathway for early, life-altering intervention.
That's an incredibly powerful example of why this matters so much. So we've seen how DCM can quietly weaken the heart's pumping ability. But what happens when the heart muscle isn't just weak, but also prone to dangerous electrical chaos? That brings us to arrhythmogenic right ventricular cardiomyopathy, or ARVC.
This sounds quite specific. What exactly is it?
Yes, ARVC is now firmly considered a genetically determined cardiomyopathy. It's got some unique features. Historically, it was characterized by lethal arrhythmias, really dangerous abnormal heart rhythms, often occurring in relatively young adults. And pathologically, it shows a distinctive replacement of the heart muscle, particularly in the right ventricle, with fibrofatty tissue.
Fibrofatty, so scar tissue and fat.
Exactly. Think of the normal heart muscle literally turning into fat and scar tissue, which obviously doesn't conduct electricity well or contract properly. Now, while some have proposed changing the name to something simpler, like arrhythmogenic cardiomyopathy, to reflect a broader range of arrhythmic phenotypes, the ARVC nomenclature is generally preserved in current medical literature for clarity and historical continuity.
The disorder classically progresses through distinct stages. First, there's often an early subclinical phase. Imaging studies might still look normal, but tragically, sudden cardiac death can, unfortunately, still occur due to that underlying electrical instability in the diseased tissue.
Even with normal scans.
Wow. Yes. Second, we see a phase where right ventricular abnormalities become obvious on imaging, often without clinical signs of overt right ventricular dysfunction. The pump might still be working okay overall, but symptomatic ventricular arrhythmias begin to develop. This indicates the electrical problem is worsening. And finally, the third stage involves progressive fibrofatty replacement and infiltration of the myocardium. This leads to severe right ventricular dilation, aneurysm formation like little outpouchings in the wall, and associated right-sided heart failure. Left ventricular dilation and failure may also arise at this stage, sometimes referred to as phase 4, signifying a more global and severe heart failure picture.
So it starts subtly but can become really quite severe. How does this progression manifest at a cellular or electrical level in the heart? What's going on down there?
Well, in that early stage, even before major structural changes, you get slow conduction and electrical uncoupling within the heart muscle. The electrical signals just don't propagate smoothly across the damaged tissue, and this can lead to fatal arrhythmias.
Like short circuits.
Kind of, yes. As the disease progresses, that fibrofatty infiltration results in what we call inhomogeneous activation, different parts activating at different times, and further delays in conduction. This creates fertile ground for more complex and dangerous arrhythmias like reentry circuits, where electrical impulses get trapped in a loop within the scarred tissue. The predominant site of cardiac involvement was historically thought to be the triangle of dysplasia, involving the RV outflow tract, an area below the tricuspid valve, and the RV apex. However, according to the latest knowledge, recent data suggests that the RV apex is actually only involved in quite advanced stages, so the early and middle stages primarily affect other areas of the right ventricle.
Okay, interesting update there.
Yes. Patients with ARVC often exhibit a typical monomorphic ventricular tachycardia, or VT, meaning the fast rhythm looks the same beat after beat. It often has a characteristic left bundle branch block morphology with a superior axis on the ECG. And you often see typical T-wave inversions in the leads looking at the right side of the heart, extending to V3 or beyond on the ECG. These are specific electrical signatures that can really alert a clinician. And there's a classic finding, though not always present, called the epsilon wave. It's seen in the right precordial leads. This is very specific, but unfortunately insensitive finding.
Specific but insensitive, maybe.
Meaning if you do see it, it's highly indicative of ARVC. But its absence doesn't rule it out because it's just not present in all cases, maybe only about 30% or so.
Got it. A helpful clue if it's there, but you can't rely on finding it.
Exactly.
That's a fascinating electrical signature. We heard about genetics playing a crucial role in DCM. Is it equally important in ARVC?
Oh, absolutely. Perhaps even more clearly defined in some ways. The classic hallmark of ARDC, that fibrofatty replacement, is directly related to aberrant signaling involving desmosomal proteins.
Desmosomal proteins.
Yeah, think of your heart muscle cells like building blocks. Desmosomes are like the specialized glue or connections, the rivets, that hold these blocks tightly together, ensuring they contract in a coordinated way and can withstand the mechanical stress of pumping.
Okay.
In ARVC, these connections aren't working right due to genetic defects. This causes the heart muscle cells, the myocytes, to detach, die, and then slowly get replaced by fat and scar tissue as the disease progresses. It's a fundamental breakdown of the heart's structural integrity at the cellular level. When a genetic cause can be identified, rare variants in genes encoding key desmosomal proteins like plakophilin-2, PKP2, desmoglein-2, DSG2, and desmoplakin DSP account for the vast majority of genetic causes of ARVC.
So problems with the glue.
Problems with the glue, exactly. These genes all play crucial roles in building and maintaining those desmosomes. Rare variants in other genes encoding desmosomal proteins like desmocolin, DSC2, junction plakoglobin, JUP, and transmembrane protein, TMMM, also cause ARVC. The Klingon gene validity curation process, which rigorously evaluates the evidence linking genes to diseases, has identified these 6 genes as having definitive evidence for causing ARVC, establishing a strong genetic link.
6 main culprits.
6 main ones, yes. The degree of locus heterogeneity, meaning how many different genes can cause the condition, is actually similar for HCM and ARVC, with 5 or fewer genes contributing to most identifiable genetic causes. This is arguably less broad than the genetic landscape we saw in DCM. However, like DCM and HCM, the genes implicated in ARVC show extensive allelic heterogeneity.
Meaning many different faults within the same gene.
Exactly. Many different specific mutations within a single gene, like PKP2, can cause the disease. This adds to the complexity of genetic testing. You have to look for many possible errors within those key genes.
Are there any specific syndromes, conditions affecting multiple body systems that are linked to ARVC genetics?
Yes. There are some really fascinating syndromic presentations. There's the autosomal recessive condition called Naxos disease, named after the Greek island where it was first described in families. Individuals with Naxos disease manifest ARVC alongside palmoplantar keratoderma, a characteristic thickening of the skin on the palms and soles, and distinct woolly hair.
Wow, heart, skin, and hair.
Yes. And molecular genetic analysis has pinpointed a specific homozygous 2-base pair frameshift deletion of the JUP gene, which encodes plicoglobin as its cause. This directly links a specific genetic defect in a desmosomal component to this multi-system disorder.
Amazing link.
And then there's a second autosomal recessive syndromic disease called Carvajal syndrome. It resembles Naxos disease in that individuals also have that palmoplantar keratoderma and woolly hair. But individuals with Carvajal syndrome typically manifest DCM, not ARVC.
DCM, so dilated, not arrhythmogenic, right?
Correct. And Carvajal syndrome is caused by a frameshift rare variant in a different desmosomal gene, DSP, desmoplakin. This distinction between Naxos, ARVC, JUP gene, and Carvajal, DCM, DSP gene, despite the very similar skin and hair findings, is a critical point. It beautifully highlights the diverse genetic pathways to cardiomyopathy and shows how the specific desmosomal gene involved can determine the type of heart muscle disease that develops.
That's incredible. So with all these complexities, how is ARVC definitively diagnosed? Is there one gold standard test?
Unfortunately, no single gold standard. The diagnosis of ARVC currently rests primarily on a combination of findings. We use clinical information, electrocardiographic features like those T-wave inversions and maybe an epsilon wave, imaging findings from echo or CMR showing RV abnormalities, and genetic testing results. These are divided into major and minor diagnostic criteria, as proposed in a revised 2010 consensus statement, often called the task force criteria. It's essentially a scoring system that helps integrate all these different pieces of evidence to arrive at a diagnosis, because no single test tells the whole story.
Okay, a multi-pronged approach. Are there other conditions that can mimic ARVC, making that diagnosis tricky sometimes?
Yes, the differential diagnosis is really important. It's crucial not to misdiagnose. In its early stages, especially before visible structural abnormalities appear on imaging, ARVC can be confused with other causes of ventricular arrhythmias originating from the right ventricle, like idiopathic RV outflow tract, VT.
Okay.
However, the morphology, or the shape, of the classic ARVC-related VT often differs from these other entities, showing that characteristic left bundle branch block pattern we mentioned. And certainly in the presence of those precordial T-wave inversions during normal sinus rhythm, ARVC should be high on the list, the initial suspected diagnosis.
Right.
Also, cardiac sarcoidosis, that inflammatory disease we mentioned earlier in the context of DCM, can occasionally mimic ARVC morphologically too. It can be indistinguishable sometimes, even with multiple imaging modalities like MRI or echo, making diagnosis incredibly challenging in certain cases.
So even the best scans might not be definitive.
Exactly. And to make matters worse, a cardiac biopsy in patients with sarcoidosis often fails to show the pathognomonic granulomas, the classic hallmark inflammatory clusters of sarcoidosis. But the biopsy might reveal extensive fibrosis or scarring, which can then also be confused with the fibrofatty changes seen in ARVC. It highlights a real diagnostic challenge for clinicians.
Definitely sounds tricky. What are the core treatment principles for ARVC once it is diagnosed? What do you tell patients?
A really crucial piece of advice for patients diagnosed with ARVC is to avoid intense physical exertion, especially competitive sports. This is because strenuous activity is strongly associated with an earlier onset of symptoms and, more worryingly, an increased risk of sustained ventricular tachycardia and potentially sudden death. It seems physical stress can really exacerbate the disease process in ARVC.
Okay, lifestyle modification is key.
Absolutely. Now, the classic monomorphic VT in ARVC, the one predominantly involving the right ventricle, is often surprisingly well tolerated hemodynamically, even at a rapid rate. This might be because left ventricular function is often preserved, at least initially, in many patients, which helps compensate. Nevertheless, VT of a different morphology can certainly occur. And sadly, sudden death is not uncommon, underscoring the serious nature of the condition and the need for effective risk stratification and treatment.
Right.
Antiarrhythmic drugs like sotalol or amiodarone can often suppress symptomatic arrhythmias, meaning they can reduce palpitations or dizziness. But importantly, they haven't been definitively shown to prevent sudden death. So they are primarily used for symptom control, not necessarily life prolongation in this context.
Okay, managing symptoms but not the underlying risk.
Precisely. Beta-blocking agents, however, are often recommended as potentially valuable in all patients with ARVC. They can help suppress those catecholamine-triggered arrhythmias, the ones initiated by stress hormones like adrenaline, and there's some thought they might also help slow the progression of ventricular dysfunction, although that's less certain. An implantable cardioverter defibrillator, or ICD, is highly recommended. It's often a cornerstone of therapy for patients who have survived a cardiac arrest, aborted sudden death, experienced syncope, fainting likely due to arrhythmia, or who have significant ventricular arrhythmias or decreased LV function. The ICD is there as a safety net to deliver a life-saving shock if a dangerous rhythm occurs.
The defibrillator is crucial for high-risk patients.
Absolutely. And then there's catheter ablation, the procedure where we try to find and cauterize the abnormal heart tissue causing the arrhythmias. Ablation has not been shown to reduce sudden death risk, so it doesn't replace an ICD for high-risk patients. However, it is very valuable for patients with an ICD who are experiencing frequent arrhythmias and getting lots of shocks, as it can significantly reduce the burden of arrhythmias. Occasionally, it might be considered for patients with very well-tolerated single morphology VT, where medications aren't sufficient or cause side effects.
Okay.
Ablation for ARVC is complex. It appears to be most successful when lesions are made on both the epicardial, the outer surface, and endocardial, the inner surface of the heart, reflecting that the disease process often involves the full thickness of the heart wall. And it really should only be performed at specialized centers with significant experience in this challenging technique.
Okay, let's shift gears to a condition that has garnered a lot of public attention, often referred to, maybe sometimes dramatically, as broken heart syndrome. What exactly is Takotsubo cardiomyopathy, or TC?
Right. Takotsubo cardiomyopathy, also known as Takotsubo syndrome, or TTS, especially in Europe, or sometimes simply stress-induced cardiomyopathy, is an acute but typically reversible condition. It was first recognized and described in Japan back in the 1990s and now has an updated, more uniform definition to help standardize diagnosis worldwide. It's a truly fascinating and powerful example of how extreme emotional or even physical stress can directly and profoundly impact heart function, mimicking a heart attack.
Mimicking a heart attack is key, isn't it?
Absolutely. The predominant symptom in the vast majority of patients, maybe around 76%, is acute chest pain. Shortness of breath or dyspnea is also common, maybe in close to half of patients. And syncope, or fainting, occurs in a smaller percentage, maybe around 7–8%.
So symptoms that would send anyone to the emergency room thinking heart attack.
Exactly. And what's really striking is the trigger. A preceding physical trigger, like a severe asthma attack, a major surgery, a serious infection, even intense pain occurred in about 36% of cases in large registries. And a preceding emotional trigger like intense grief, extreme fear, sudden shock, even sometimes intense anger or a heated argument occurred in about 28%.
So a major stressor, physical or emotional.
Usually, yes, though sometimes a trigger isn't identified. And adding to the confusion with a heart attack, blood tests often show elevated troponin values. That marker usually associated with heart muscle damage in about 87% of patients. And the ECG may show ST elevation in almost half of them, again mimicking a classic heart attack ECG pattern.
Yeah.
This is why a coronary angiogram is absolutely crucial in the acute setting to rule out obstructive coronary artery disease.
You need to see those clear arteries.
Precisely. That's often the defining moment in the diagnosis.
Are certain groups more susceptible to Takotsubo, or is it something anyone could experience under extreme stress?
While men can certainly be affected, women are overwhelmingly more likely to experience TC, about tenfold more likely overall.
Tenfold? Wow.
Yes, and specifically, postmenopausal women, those older than 55 years, are about 5 times more likely to experience TC compared to women less than 55 years old. This strongly suggests a potential hormonal link, perhaps related to the decline in estrogen levels after menopause, which might make the heart more vulnerable to stress hormone surges.
Interesting.
Interestingly, among those younger than 50 years who developed TC, men were actually more commonly affected in some studies. And these younger patients, both male and female, often had more antecedent neurological or psychiatric disorders compared to older individuals who developed TC. This suggests maybe different risk profiles and perhaps slightly different mechanisms at different ages.
Okay. What's actually happening inside the body during Takotsubo? What's
Yeah.
the mechanism behind the broken heart? How does stress do this?
That's the million-dollar question, and we don't have all the answers yet. But the leading theory centers on the sympathetic nervous system, our body's fight or flight response. It appears absolutely central to this condition, without identifiable emotional or physiological stimulus preceding onset in most cases. This massive, sudden surge of catecholamine stress hormones, like adrenaline and noradrenaline, is thought to essentially overwhelm the heart muscle cells, causing them to temporarily stun or malfunction.
A catecholamine storm.
Exactly, a catecholamine storm hitting the heart. One theory, called multivessel epicardial coronary artery spasm, postulates that the main coronary arteries themselves constrict diffusely everywhere, not just in one spot like a typical blockage. This would lead to widespread but temporary blood flow issues, explaining the generalized contractile abnormalities that don't follow specific coronary artery territory. Abnormalities of the coronary microcirculation, the tiny blood vessels deep within the heart muscle that aren't visible on an angiogram, have also been postulated as a mechanism. Maybe these small vessels spasm or malfunction under stress.
And genetics.
Familial clustering has only rarely been observed, so it doesn't seem to run strongly in families like DCM or ARVC. If genetics are at play, it may be more subtle, perhaps involving common genetic variants, polymorphisms, that make someone's adrenergic signaling pathways, their response to stress hormones, more sensitive or amplified, rather than a single dominant gene mutation causing the disease directly.
Okay, more of a predisposition, perhaps.
Oh.
How did this stress-induced phenomenon visually impact the heart's pumping chamber when doctors look at it with, say, an echocardiogram?
This is where the classic description comes from. Typically, Takotsubo primarily affects the left ventricular apex, the very bottom tip of the heart. This leads to its synonym, apical ballooning syndrome, which occurs in more than 80% of patients. What you see is the apex basically stops contracting, it becomes akinetic or dyskinetic, and it balloons outwards during systole when the heart contracts, while the base of the heart, the part near the valves, often contracts normally or even hyperdynamically, trying to compensate.
And that shape.
That shape, with the narrow neck at the base and the ballooned apex, resembles a traditional Japanese octopus fishing pot, which is called a takotsubo, hence the name.
Oh, okay. I always wondered.
Yeah. However, it's important to note that the pattern isn't always apical. Regional wall motion abnormalities may sometimes be limited to the midventricular wall, or sometimes even involve the base while the apex is spared, or other variations. So while apical ballooning is classic, Takotsubo can present with different patterns of stunning.
Right.
And this unique pattern, particularly the apical ballooning with the hyperdynamic base, can lead to another complication. It can result in acute LV outflow tract obstruction.
Obstruction? How?
Because the base is squeezing so hard, it can actually pull the mitral valve leaflet forward during contraction, something called systolic anterior motion, or SAM, partially blocking the path where blood needs to exit the heart. This creates a pressure gradient, making it harder for blood to get out, and can potentially lead to significant hypotension or low blood pressure.
Wow, so the heart can obstruct itself in this situation.
It can, yes. It's a dynamic obstruction caused by the abnormal contraction pattern.
Despite it being generally reversible, does Takotsubo carry any serious risks in that acute phase in the hospital?
Absolutely. While the long-term prognosis is generally considered good once the heart recovers, the acute phase can be quite dangerous. An in-hospital mortality rate of around 4.1% has been reported in large international registries, which is significant and comparable to some types of heart attacks.
Okay, so it's not benign acutely.
Definitely not. This mortality is primarily due to potential acute complications like irreversible cardiogenic shock, where the stunned heart simply can't pump enough blood to sustain the body's needs. LV rupture, a tear in the heart wall, is rare but catastrophic when it occurs. Embolization of LV thrombi blood clots forming in that akinetic stagnant apex can travel to the brain, causing a stroke, or to other parts of the body. And malignant ventricular arrhythmias can occur, particularly a type called torsades de pointe, which is often associated with Takotsubo-related QT prolongation, an electrical abnormality seen on the ECG reflecting delayed repolarization. Complete heart block, where the electrical signals are completely disrupted, can also occur, though rarely.
So a lot can go wrong initially. Given its often reversible nature, what's the standard approach to managing Takotsubo in the hospital? How do you support the heart while it recovers?
Well, the good news is that TC is generally a self-limited disorder. It usually resolves on its own, often with rapid resolution of symptoms and that LV dysfunction, typically within days to weeks. The heart muscle stenting is temporary. Because of the potential for serious complications early on, classification into lower risk and higher risk categories has been recommended. The higher risk category is often based on factors like having a very low LV ejection fraction, less than 45% indicating significant weakness, having hypotension, low blood pressure, having that LV outflow tract gradient we discussed, greater than 40 millimeter Hg, and or the presence of significant arrhythmias.
Okay, so stratifying the risk.
Exactly. This helps clinicians identify patients who need more intensive monitoring and potentially more aggressive support. For higher risk groups, the use of supportive medications like an ACE inhibitor or a beta blocker, or sometimes both, is often recommended to help reduce the heart's workload and potentially blunt the effects of those ongoing stress hormones.
Makes sense.
Because of that occasional association with acute QT prolongation, great care should be taken to avoid using other medications that are known to prolong the QT interval, such as certain antibiotics like macrolides or certain antiarrhythmic agents, as these could worsen the electrical instability and increase the risk of torsades de pointe.
Right. Avoid making things worse.
Precisely. If hypotension is present, pressors, medications used to raise blood pressure, should be used with caution, especially if there's evidence of that LV outflow tract obstruction, as some pressors could actually worsen the obstruction. It's a delicate balance. Occasionally, thrombus formation or blood clots can occur in that dyskinetic, non-moving apex. So anticoagulation or blood thinners is routinely used if a thrombus is seen, or sometimes prophylactically in high-risk patients, to prevent embolization. And generally, the acute phase of TC typically requires observation in an intensive care unit, ICU, or a monitored step-down unit setting, simply due to the risk of these major adverse events occurring unexpectedly in the first few days.
Okay, close monitoring is key initially. What about the long-term outlook? Specifically, the risk of it happening again. Is recurrence a major concern?
The recurrence risk is estimated at about 5%, maybe a bit higher in some studies, usually occurring within the first year after the initial event. So it's relatively low, but it's certainly a concern for patients who've been through it. Once the fear of it happening again can be significant.
Understandably.
Interestingly, the overall long-term mortality of patients who've had TC has been estimated in some studies to be similar to that of patients who've had a myocardial infarction due to coronary disease, even though most TC patients have no demonstrable atherosclerotic plaque.
That's surprising. Why would that be?
It's not entirely clear. It suggests that perhaps the underlying vulnerability to stress, or maybe other coexisting health issues often found in these patients, contributes to long-term risk. Even after the heart muscle function recovers from the Takotsubo event itself, it's an area of ongoing research.
Okay. Are there treatments to prevent recurrence?
While long-term use of ACE inhibitors has been shown in some observational studies to be associated with a reduced recurrence rate, providing a potential pharmacological intervention, although definitive randomized trial data is limited. In contrast, perhaps counterintuitively, prophylactic use of beta blockers long-term has not been consistently shown to reduce recurrence, even though attempting to minimize a catecholamine-induced trigger provides a strong theoretical rationale for their use. The evidence just isn't strong there for prevention. Interesting. Similarly, treatment for depression or other psychiatric disorders, which are common in patients who experience TC, has been postulated to possibly reduce recurrence by managing underlying stress triggers. But again, strong evidence is lacking, largely due to the difficulty of conducting controlled trials, given the relatively low recurrence rate. And even if a visualized thrombus mandates anticoagulation acutely, long-term anticoagulation is generally not recommended for all TC patients once the acute risk has passed and the LV function has recovered, unless there's another indication for it.
Let's illustrate Takotsubo with another real-world scenario. Think of Maria, a 62-year-old grandmother. She's rushed to the emergency room with sudden severe chest pain and breathlessness. This happened shortly after she learned her beloved grandson was in a serious accident.
Oh dear, a classic emotional trigger.
Exactly. Her initial ECG and troponin levels look alarming, just like a heart attack, and the medical team is ready to treat her for that. But then, the crucial test. A coronary angiogram shows perfectly clear arteries, no blockages whatsoever. What was likely going on, and how did this understanding help her?
This is just a textbook presentation of Takotsubo cardiomyopathy.
Oh.
You have the clear, potent, acute emotional trigger, the terrible news about her grandson. You have the classic heart attack-like symptoms. You have the ECG changes and the elevated troponin. But then the defining feature, the completely normal coronary arteries on the angiogram.
Right.
Her echocardiogram, performed shortly after, likely showed that characteristic apical ballooning, where the bottom part of her left ventricle was essentially stunned and paralyzed, while the base was probably contracting vigorously, giving it that distinct octopus pot shape.
So what was the practical application of recognizing this specific cardiomyopathy for Maria? How did it change her care?
The practical application was absolutely immense, crucial, really. Instead of treating her for a heart attack, which would involve potentially harmful antiplatelet drugs, possibly high-dose statins, and maybe even unnecessary invasive procedures like stenting if they thought there was a blockage they missed, the team could pivot.
Right.
They focused on supportive care. They monitored her carefully in the ICU for those potential complications like arrhythmias or heart failure. They managed her symptoms, maybe gave her some gentle diuretics if she had fluid buildup, and maybe started a beta blocker to help calm her stressed sympathetic nervous system. They avoided unnecessary interventions and allowed her heart to recover naturally, which it usually does in Takotsubo. Within days, Maria's heart function likely began to normalize on repeat echoes. She was able to return home, receiving guidance on stress management techniques and, of course, appropriate follow-up.
So it spared her unnecessary treatments and focused on supportive care.
Exactly. This case perfectly highlights how accurately identifying TC spares patients from potentially harmful or unnecessary treatments aimed at coronary artery disease and allows for a tailored approach that leverages the heart's remarkable intrinsic capacity for recovery in this specific condition. It's a powerful reminder that not all acute chest pain and ECG changes mean blocked arteries.
We'd seen how acute stress can temporarily stun the heart. Now, what about just a relentlessly fast heart rate? Can that, on its own, cause heart damage over time, even without a sudden stressor?
Absolutely it can. This brings us to a distinct condition called Tachycardia-induced cardiomyopathy. This condition describes how a prolonged period of tachycardia, which just means a rapid heart rate, whether it's regular or irregular, can directly result in both diastolic and systolic ventricular dysfunction.
So problems relaxing and pumping.
Exactly. The heart struggles both to relax and fill properly between beats and to pump blood effectively during the beat. And this can happen even in the absence of any other underlying cardiac diseases. It's a unique diagnosis because it can only truly be made retrospectively.
Retrospectively, how so?
Meaning, you suspect it when you see someone with heart failure symptoms and a persistently fast heart rate. But you can only confirm the diagnosis when the correction of that arrhythmia, whether through medication or a procedure like ablation, is then associated with a clear improvement or even normalization of the ventricular function.
Ah, so fixing the rate fixes the heart function.
If it's truly tachycardia-induced cardiomyopathy, yes, it's like the heart is just exhausted from running a constant marathon, and once you let it rest by slowing the rate, it recovers. So this condition should be considered in any patient who presents with persistent tachycardia and left ventricular systolic dysfunction, especially if they are not in a normal sinus rhythm. And the cardiomyopathy may manifest either as an isolated condition where the rapid heart rate is thought to be the sole cause of the problem, or it can occur in association with pre-existing cardiac disease, making things worse. For example, think of a patient with mild, previously stable DCM. If they then develop persistent atrial fibrillation with a rapid ventricular rate, they may suddenly develop decompensated heart failure. This isn't just because they lost the atrial kick to filling, but also because the rapid irregular heart rate itself leads to further systolic dysfunction, creating a kind of vicious cycle of heart strain.
Okay, it could be primary or make something else worse. So what kinds of arrhythmias are typically responsible for this kind of heart damage? Is it just any fast rhythm?
Well, the purest form of tachycardia-induced cardiomyopathy, the clearest examples, are probably those caused by incessant or extremely frequent supraventricular tachycardias. Things like persistent atrial tachycardia, where the upper chambers just fire off rapidly all the time, or something called permanent reciprocating junctional tachycardia, which is often seen in children or younger patients who present with systolic dysfunction.
Incessant meaning nonstop.
Essentially, yes. Rhythms that are continuously fast, day in, day out, giving the heart absolutely no rest. However, almost any chronic or very frequent arrhythmia can potentially cause it. This includes very frequent premature ventricular contractions, or PVCs, those extra heartbeats originating in the lower chambers. If someone has tens of thousands of these a day, it can sometimes lead to cardiomyopathy. Or recurrent non-sustained VT, where short bursts of fast ventricular rhythm occur repeatedly throughout the day. And sometimes, incessant atrial tachycardia causing this cardiomyopathy can even be mistaken for simple sinus tachycardia, a normal fast heart rate response to stress or exercise, just because the heart rate is fast. If a previous ECG is available from when the patient was known to be well, comparison can be incredibly helpful. You have to pay specific attention to subtle differences in the shape of the P wave, which indicates the atrial activity, as this can distinguish an abnormal atrial rhythm originating somewhere unusual from a normal sinus rhythm originating from the heart's natural pacemaker.
That's a crucial distinction to make. Is it the sheer speed of the heart rate, how fast it's going? Or is it more about how long it stays fast that matters most for causing this damage?
That's a really interesting point. What the evidence suggests is that the duration of the arrhythmia, more than the actual heart rate itself, as long as it's consistently fast, is probably the more critical factor in developing tachycardia-induced cardiomyopathy.
Duration over speed.
It seems so. For instance, there was a study looking at 30 patients who had incessant atrial tachycardia and developed this cardiomyopathy. The mean duration of their symptoms before diagnosis was 6 years, but the mean ventricular response rate was only 117 beats per minute.
117. That does sound crazy fast.
No, it's not extremely rapid like you might see in some acute arrhythmias, but it was constant, relentless for years. And crucially, rate or rhythm control, primarily achieved through catheter ablation. In that study, a procedure that electrically corrects the abnormal rhythm by targeting the source was associated with normalization of the ejection fraction, the pumping function, in all but one patient.
Wow, almost complete recovery.
Yes, it really highlights the heart's remarkable ability to recover once that constant stress of the fast rhythm is removed.
So if correcting the arrhythmia is the key, how quickly does the heart recover once that's done? Is it immediate?
Well, a decreased ejection fraction in the presence of atrial fibrillation, for example, may occasionally improve after you restore normal sinus rhythm, perhaps with cardioversion or ablation. However, if the ventricular rate in atrial fibrillation is already well controlled with medications, just converting back to sinus rhythm doesn't often lead to a significant improvement in LV systolic function if there is an underlying cardiomyopathy already present. This kind of underscores that simply controlling the rate might not be enough if the underlying rhythm problem isn't fixed or if there's other heart muscle disease.
Okay.
And it's really important to assess ventricular rate control properly, often with 24-hour Holter monitoring, to confirm that the rate is controlled not just at rest, but also during exercise and daily activities, as the rate can fluctuate significantly. Now, for those patients with PVC-associated tachycardia-induced cardiomyopathy, most tend to have a very high burden of PVCs, often more than 20,000 PVCs over a 24-hour period, maybe 20–30% of all their heartbeats. But the condition has also been described with a lesser frequency, maybe 10–15% PVC burden in some susceptible individuals. Catheter ablation to target and eliminate the source of these PVCs, if possible, is generally associated with significant improvement, sometimes normalization, of ventricular function in these patients. It can be a very effective treatment.
And the timing of recovery.
While most patients show improvement relatively quickly, perhaps within weeks to months after successful ablation or rhythm control, occasionally patients have been seen with late improvement, sometimes taking up to a year or even longer for the heart function to fully recover. So patience and continued monitoring are important after an intervention. Don't give up too early. And one final point on assessment. Because the rapid irregular ventricular response during atrial fibrillation is associated with marked beat-to-beat variation in how much blood is ejected, getting a single ejection fraction measurement during AFib can be tricky. So the most accurate way to determine whether a true improvement in systolic function has really occurred after restoring sinus rhythm is often to evaluate the ejection fraction relatively early after the conversion, and then compare it with a reevaluation maybe 3 to 6 months later. This gives the heart adequate time to remodel and show its true potential for recovery.
Now let's explore peripartum cardiomyopathy, or PPCM. The name itself strongly suggests a link to pregnancy and the time around childbirth. How exactly does this condition manifest?
Indeed, PPCM is defined as a dilated cardiomyopathy, so an enlarged, weakened heart that occurs specifically in a temporal relationship to pregnancy. That time frame is usually defined as occurring late in pregnancy, typically the last month, or during delivery itself, or most commonly in the first few months postpartum, usually within 5 or 6 months after delivery.
Okay, a specific window.
Yes. It's increasingly recognized as an important and potentially life-threatening condition that can affect otherwise healthy women during this uniquely vulnerable period of their lives.
And how does it relate to the DCM we talked about earlier? Is it completely separate?
That's a great question, and the thinking on this has evolved. While PPCM was traditionally considered etiologically separate from general DCM, evidence now clearly indicates that at least a portion of PPCM cases result from an underlying genetic risk, specifically from variants in genes already known to cause DCM.
So the same genes can be involved.
Exactly. Definitive evidence of this was shown relatively recently in a study of 172 women with PPCM who underwent genetic sequencing for known DCM genes. They found TTN truncating variants, those mutations in the Titin gene we discussed for DCM, in 26 of those women, which is about 15%.
15%.
And that 15% frequency of TTN truncating mutations is very similar to the frequency found in general cohorts of patients with DCM who aren't pregnant. This strong similarity suggests that at least a portion of PPCM cases may simply be underlying DCM that happens to manifest or become clinically apparent during the significant physiological stress of pregnancy. Pregnancy might be the second hit that unmasks a pre-existing genetic susceptibility.
So is it just DCM that happens to pop up during pregnancy, or are there unique factors specific to pregnancy that contribute to PPCM, maybe even in women without those DCM genes?
This raises another important question. While a genetic predisposition like a TTN variant might be present in some women, obviously only a very small fraction of all women harboring such a variant actually develop PPCM when they become pregnant. Most don't. So this strongly suggests that additional risk factors must play a crucial role. These could be other genetic factors, maybe epigenetic modifications, changes in how genes are expressed, or perhaps endogenous environmental factors unique to pregnancy. These additional factors could range from things like autoimmune conditions being triggered or worsened by pregnancy, potential nutritional deficiencies, or perhaps inflammation of the myocardium, myocarditis, that could be triggered by viral infections or the hormonal changes of pregnancy.
Okay, so genetics might load the gun, but pregnancy pulls the trigger.
That's a common analogy used, yes. And there's also been a lot of focus on vascular hormonal features associated with PPCM. Animal models have pointed towards elevated levels of prolactin, the hormone involved in milk production, and specifically an abnormal fragment of prolactin potentially playing a role. This, along with other vascular changes in late pregnancy, has contributed to a vascular hypothesis, suggesting that abnormal signaling involving prolactin and other factors might damage the small blood vessels of the heart or directly harm heart muscle cells.
Prolactin. Interesting. Has that led to treatments?
Well, based partly on this hypothesis and some early uncontrolled studies, a drug called bromocriptine, which inhibits prolactin secretion, was advocated for treatment. However, more recent randomized studies, although some still lacked a true placebo control group, have shown no convincing benefit from adding bromocriptine to standard heart failure therapy. Plus, bromocriptine can have significant adverse effects, like increasing the risk of blood clots. So, currently, a properly randomized placebo-controlled trial is still needed to definitively demonstrate benefit before it can be widely recommended. The jury is still out on bromocriptine for PPCM.
Okay, not standard practice yet. Who's most at risk for PPCM, and how does it usually present to a clinician? What should women and doctors look out for?
Well, the incidence varies, but in the U.S., it's estimated to be somewhere between 1 in 1,000 and 1 in 4,000 live births. A major risk factor appears to be African ancestry. Significantly higher incidence rates have been reported in countries with predominant African ancestry, like Nigeria and Haiti, which points towards possible genetic or perhaps environmental factors specific to these populations, although the exact reasons aren't fully understood.
Okay, other risk factors.
Yes, other risk factors include preeclampsia, that pregnancy complication involving high blood pressure and organ stress. Also, older maternal age seems to increase risk, as do multiple fetus pregnancies carrying twins or more, all of which obviously add significant physiological stress to the mother's cardiovascular system.
Makes sense. And the symptoms.
In patients with PPCM, the symptoms and signs of heart failure develop during that specific window late pregnancy or, more often, after delivery. The symptoms themselves are similar to those of any patient with heart failure caused by LV systolic dysfunction. Shortness of breath, especially with exertion or when lying flat, fatigue, swelling in the legs or feet, edema, maybe a cough. Most diagnoses are made in the first 4 months following delivery, though prepartum diagnoses, when it's caught before delivery, are most commonly made in the last month of pregnancy. However, the disorder has also been described occasionally in early pregnancy, sometimes termed pregnancy-associated cardiomyopathy in those cases.
And I imagine diagnosis can be tricky.
It can be because many of those symptoms like shortness of breath, fatigue, and some ankle swelling can also occur to some degree in a perfectly normal pregnancy, especially late in the third trimester.
Right, they overlap.
Exactly. So it's possible that a proportion of PPCM cases experience a delayed diagnosis because the symptoms are initially dismissed, perhaps by the patient or even the doctor, as just normal pregnancy discomforts. Furthermore, because we know that spontaneous resolution of the LV dysfunction can occur in a significant number of PPCM patients, it's plausible that milder cases occurring in the peripartum period might unfortunately be overlooked entirely, potentially leaving some women undiagnosed and without appropriate follow-up or counseling about future pregnancy risks.
That's concerning. What about those future pregnancies? Is recurrence a major concern for women who've experienced PPCM, and what guidance is given?
Recurrence is definitely a major concern and a key counseling point. Given the relative rarity of the disease overall, it's actually not possible to precisely determine the exact incidence of PPCM recurrence in subsequent pregnancies for women who have had a previous episode. We don't have huge numbers to study. However, recurrence risk appears to be strongly related to the degree of recovery of heart function from the initial episode. PPCM seems much less likely to recur in women who enter a subsequent pregnancy with completely normalized left ventricular function, a normal ejection fraction, and heart size.
So full recovery is key before considering another pregnancy.
That seems to be the case. It suggests a paradigm of remodeling and reverse remodeling, similar to what we see in other conditions affecting LV size or function. If the heart fully recovers, the risk is lower, although likely not zero. If LV function remains impaired, the risk of worsening heart failure or recurrence during a subsequent pregnancy is considered very high, and future pregnancy is often strongly discouraged. So from these studies and observations, a key recommendation emerges. For any dilated cardiomyopathy occurring during or following pregnancy, the same general guidelines for investigating and managing DCM should be followed. This means obtaining a comprehensive family history, performing clinical screening of first-degree relatives, especially given that potential genetic link with TTN variants, and strongly considering genetic testing as part of the evaluation. This proactive approach is crucial, both for the patient's own long-term management and for identifying potential risks in her family members.
Our source material also briefly touches upon left ventricular noncompaction, or LVNC. It sounds like a structural issue with the heart muscle itself. What's the core idea here? It seems a bit controversial or hard to define.
Yes, that's a good way to put it. Defining the LVNC phenotype has been, frankly, significantly complicated by the use of various different diagnostic criteria, particularly using echocardiography or cardiac CMR. This has led to wildly varying estimates of its frequency in population-based studies, sometimes as high as 23%, which seems implausibly high and likely reflects overdiagnosis based on some criteria.
Okay, so the definitions aren't consistent.
Exactly. What's particularly challenging is that studies comparing different diagnostic methods have found poor agreement. For instance, one study found that the concordance of 3 different common echocardiographic diagnostic schemata was congruent in only about 30% of cases. That highlights the significant diagnostic ambiguity and the difficulty clinicians face in consistently and reliably identifying this entity. Various diagnostic criteria have been proposed and summarized over the years, including at least 4 based on echocardiography and 2 based on cardiac CMR. This reflects the ongoing efforts to try and standardize its identification and improve diagnostic accuracy. But the basic concept of LVNC is a condition where the heart muscle, particularly in the left ventricle, looks somewhat spongy. It fails to fully compact during development, leaving prominent muscle bundles called trabeculations and deep recesses between them. This abnormal structure can potentially lead to problems with heart function, systolic dysfunction, arrhythmias, and blood clot formation within those recesses. But distinguishing true pathological non-compaction from just prominent normal trabeculations remains a challenge.
Okay, finally, let's turn our attention to alcoholic cardiomyopathy. This sounds like a condition that is a direct and perhaps devastating consequence of lifestyle choices. What defines this condition?
Indeed. Alcoholic cardiomyopathy occurs when heavy alcohol drinking, engaged in for prolonged periods of time, directly damages the heart muscle, affecting both its systolic pumping and diastolic relaxing function. Eventually, this can lead to overt heart failure.
And what constitutes heavy drinking in this context?
Generally, heavy alcohol drinking sufficient to cause cardiomyopathy is considered to be more than 90 grams per day of alcohol consumed for 5 years or more.
90 grams. How much is that in terms of actual drinks?
Right. It's useful to put that in perspective. A standard drink in the U.S., like a 12-ounce beer, a 5-ounce glass of wine, or 1.5 ounces of hard liquor, contains about 14 grams of alcohol. So 90 grams per day is roughly equivalent to 6 or 7 standard drinks every day for at least 5 years.
Wow, that's a significant and sustained level of consumption.
It really is. It places immense strain on the heart over time. And it's not a new discovery, although perhaps underappreciated. Its existence has been recognized for over a century. William Mackenzie first described the cardiac effects of alcohol way back in 1902, calling it alcoholic heart disease. And the numbers are significant. As many as 30% of chronic heavy alcohol users show some evidence of left ventricular dysfunction on echocardiography, even if they aren't fully symptomatic yet. And alcoholic cardiomyopathy is estimated to represent approximately 20% to 30% of all cases of non-ischemic dilated cardiomyopathy.
So a big chunk of DCM cases might be related to alcohol.
A very significant proportion, yes. Which underscores how important taking a detailed alcohol history is when evaluating someone with unexplained heart failure.
Are there specific factors that increase the risk beyond just the amount and duration of heavy drinking? Or who is most vulnerable?
Yes, certainly the amount consumed per day and the total duration of heavy alcohol use are clearly associated with a higher incidence of cardiomyopathy. There's a clear dose-dependent and time-dependent toxic effect. What's particularly striking, and perhaps not widely known, is that women appear to be more susceptible to developing the disease, potentially developing cardiomyopathy at lower cumulative levels of alcohol consumption compared to men.
Really? Why is that?
The exact reasons are still being explored, but it might be due to differences in how men and women metabolize alcohol, differences in body size and composition, or perhaps hormonal influences. But it's a consistent finding that women seem more vulnerable to alcohol's toxic effects on the heart.
Okay. And the clinical picture, how does it present?
The clinical picture of alcoholic cardiomyopathy can range quite widely. It can go from completely asymptomatic cardiac abnormalities, where the heart damage is only picked up on an imaging test done for other reasons, all the way to clinically advanced congestive heart failure. When symptoms do develop, they are typical heart failure symptoms: dyspnea, shortness of breath, chronic fatigue, reduced exercise tolerance. On physical examination, clinicians might find those classic signs of fluid overload due to the struggling heart: jugular venous congestion, bulging neck veins, rales or crackling sounds in the lungs, and peripheral edema or swelling in the legs and ankles.
Standard heart failure signs. What do the various diagnostic tests typically show specifically for alcoholic cardiomyopathy?
Right. The ECG findings are often nonspecific. It might show sinus tachycardia, a fast but regular heart rhythm, especially if someone is acutely intoxicated or withdrawing. You can see nonspecific ST and T wave abnormalities, just general electrical changes. Right and left bundle branch block indicating conduction delays can also be seen. And various atrial and ventricular arrhythmias are common, particularly atrial fibrillation.
Okay. And imaging.
Chest radiography, the chest X-ray, often shows cardiomegaly, an enlarged heart silhouette, and signs of pulmonary congestion or fluid in the lungs, especially when patients are in decompensated heart failure. Echocardiography is really key. It reveals that often the earliest detectable abnormality in heavy alcohol drinkers is actually diastolic dysfunction.
Diastolic dysfunction first.
Yes, where the heart struggles to relax and fill properly between beats. This is often present in at least 1/3 of asymptomatic patients with chronic heavy alcohol use, highlighting it as an early, often silent indicator of alcohol-related heart damage, even before the pumping function declines.
That's important. An early warning sign.
Exactly. With continued heavy drinking and disease progression, global systolic dysfunction eventually ensues, where the heart muscle weakens and can't pump effectively. At this point, the echocardiogram may become indistinguishable from advanced idiopathic non-ischemic cardiomyopathy, which again emphasizes why that detailed alcohol history is absolutely essential for making the correct diagnosis.
Right.
In advanced cases, the echo might also detect atrial and ventricular thrombi, blood clots, forming in the sluggishly moving blood within the enlarged heart chambers. These clots are dangerous because they can break off and lead to systemic embolization, causing a stroke if they travel to the brain or damaging other organs. And advanced echo techniques like strain echocardiography, which looks at the deformation of the heart muscle itself, can also detect subtle abnormalities in how the heart muscle contracts and relaxes, sometimes even before the overall ejection fraction drops significantly.
Is there anything unique about the heart tissue itself that differentiates alcoholic cardiomyopathy from other forms of DCM when you look under a microscope?
That's a good question. The histopathology, meaning what the heart tissue looks like microscopically of alcoholic cardiomyopathy, is actually quite similar to general idiopathic dilated cardiomyopathy. In many ways, you see enlarged heart muscle cells, some fibrosis. However, there is a notable difference that's often described: a lower myocyte count.
Fewer heart muscle cells.
Yes, fewer heart muscle cells seem to be present in histologic sections compared to non-alcoholic DCM. This suggests that alcohol causes not just dysfunction, but perhaps direct cellular damage and death, leading to a loss of the heart muscle cells themselves. It's a tangible sign of its destructive power at the cellular level.
Wow. What does the long-term outlook look like for these patients? Is there hope for recovery, or is the damage permanent once it occurs?
The prognosis is variable, but it really hinges on one critical factor: alcohol consumption. There was an important study by Buzo Morello and colleagues that followed 94 consecutive patients diagnosed with alcoholic cardiomyopathy for a median of about 5 years. In that study, unfortunately, 5% of patients died from progressive heart failure, another 8.5% experienced sudden death, likely from arrhythmias, and 15% ended up needing a heart transplant. So it can certainly have very serious consequences if drinking continues.
Significant mortality and morbidity.
Yes. But crucially, the remaining patients in that study, the majority either remained clinically stable or, quite remarkably, significantly improved after reducing or ideally stopping their alcohol intake. This really emphasizes the incredible potential for reversibility of the condition if the toxin is removed.
That's a huge point of hope.
Absolutely. Factors that were associated with a poor prognosis in that study included having atrial fibrillation, not being on beta blocker therapy, which is standard for heart failure, and having a wide QRS duration on the ECG, longer than 120 milliseconds, which indicates more significant electrical conduction problems. This highlights the importance of both timely medical intervention and those profound lifestyle changes.
So what's the primary treatment then for alcoholic cardiomyopathy? What's the most important thing?
The general management of alcoholic cardiomyopathy parallels the standard evidence-based treatment for heart failure with a reduced ejection fraction. That means using those pillar medications like ACE inhibitors, beta blockers, MRAs, and diuretics as needed. However, the absolute first, most major, most critical component of treatment is complete abstinence from alcohol drinking.
Abstinence is number one.
It is the cornerstone of therapy. It's the single most impactful intervention. Patients who completely stopped drinking, or even those who significantly decreased their drinking down to mild or moderate levels, demonstrated remarkable improvement in their left ventricular ejection fraction upon follow-up in multiple studies. In fact, some studies show that patients who achieve and maintain complete abstinence from alcohol may actually normalize their ejection fraction, getting back to completely normal heart function, sometimes in as little as 1 year.
1 year. That's incredible potential for recovery.
It truly is. It's a powerful message of hope and recovery for patients who are often told their heart failure is irreversible. With alcohol removed, the heart has an amazing capacity to heal itself.
Are there other ways alcohol impacts the heart, even outside of developing full-blown cardiomyopathy? Does moderate drinking have effects?
Absolutely. Alcohol can cause various problems beyond chronic cardiomyopathy. It can cause electrolyte abnormalities like low potassium or magnesium, especially with binge drinking. And these can significantly affect heart rhythm and electrical stability, potentially triggering arrhythmias. And the most common arrhythmia seen, and one that needs more attention in the clinical setting, is atrial fibrillation. There's a strong link between alcohol consumption, especially binge drinking, and episodes of AFib.
Ah, the holiday heart syndrome.
Exactly. That term refers to this phenomenon where cardiac arrhythmias, mainly atrial flutter and atrial fibrillation, occur in individuals, sometimes without prior heart disease, after episodes of heavy drinking, often during weekends or holidays. Ventricular arrhythmias can also occur with heavy alcohol drinking and may even be fatal in some cases, especially in individuals with underlying heart conditions or electrolyte disturbances.
Okay. What about the idea of moderate drinking being good for the heart? We hear that sometimes.
Right, that's a common point of confusion. There's a described V-shaped or J-shaped curve that often characterizes the relationship between alcohol drinking and overall mortality, or sometimes specific cardiovascular risks like coronary artery disease. This suggests that people who drink very moderately, and the definition is key here, might have slightly lower risk for certain outcomes compared to people who don't drink at all, or compared to people who drink heavily. But as consumption increases beyond that very moderate level, mortality risk quickly rises sharply.
What counts as moderate?
For men, moderate is typically defined as up to 2 standard drinks per day. And importantly for women, due to those differences in metabolism and susceptibility we mentioned, it's only up to 1 standard drink per day.
1 for women, 2 for men.
Generally, yes. And remember, a drink is considered 12 ounces of beer, 5 ounces of wine, or a mixed drink containing 1.5 ounces of 80-proof hard liquor. However, and this is absolutely vital, major health organizations like the American Heart Association, AHA, do not recommend that people start drinking alcohol if they don't already, specifically to try and lower their cardiovascular risk.
Right. Don't start for health benefits.
Absolutely not. The potential harms of alcohol, including addiction, accidents, liver disease, certain cancers, and the cardiomyopathies we've discussed, generally outweigh any potential minor cardiovascular benefit for non-drinkers. If you don't drink, don't start. If you do drink, do so only in moderation within those recommended limits. That's the key public health message.
Let's conclude with a final story that really illustrates the profound power of lifestyle change and getting the diagnosis right. Consider David, a 55-year-old man. He'd been a heavy drinker for over 20 years. He gets diagnosed with advanced heart failure. Initially, his doctors attributed it to idiopathic dilated cardiomyopathy, just based on his overall health profile, perhaps not digging deep enough into the alcohol history. He felt overwhelmed, hopeless, thinking his condition was irreversible. However, one insightful clinician, maybe taking more detailed history later, noted his prolonged history of significant alcohol intake and suspected a different diagnosis might be at play. What happened next for David, and what was the key takeaway from his journey?
This is such a powerful example of how a thorough history and critically arriving at the correct diagnosis can literally change a life trajectory. The clinician suspected alcoholic cardiomyopathy, recognizing that clinically and on echo, it can look identical to idiopathic DCM. The differentiating factor is the history. So the critical step for David, the absolute non-negotiable part of his treatment plan, became the insistence on complete alcohol abstinence. Now, initially, David was resistant. As you can imagine, after 20 years of heavy drinking, it was deeply ingrained in his life, perhaps a coping mechanism. But with unwavering support from his family and his medical team, who explained the potential for recovery, he committed to it.
That must have been incredibly hard.
Immensely hard. But the payoff.
What was the practical, life-changing application of this commitment for David?
The practical application was nothing short of remarkable. Within just 6 months of stopping alcohol completely, David's heart function, measured by his ejection fraction on echo, showed significant improvement. And after 1 full year of complete abstinence, his heart function had essentially normalized, back to normal. A feat that is rarely, if ever, seen in true idiopathic DCM, which often progresses despite standard medical therapy.
Normal function after a year. Incredible.
It truly is. This wasn't just about managing symptoms better. It was a profound reversal of the underlying disease process. David's story powerfully underscores that for alcoholic cardiomyopathy, the most potent medicine available isn't a pill, although medications help support the recovery. The most potent medicine is that fundamental change in lifestyle, removing the toxin. It transformed what seemed like an irreversible end-stage condition into one with a clear path to full recovery, highlighting the incredible regenerative capacity of the heart when the underlying cause, the ongoing injury, is removed. It's a profound message of hope and the impact of personal agency with support in reclaiming health.
So after covering all this ground, what are the biggest, most impactful takeaways from our deep dive into cardiomyopathies today? What should listeners really hold on to?
Yeah, if we try to connect the dots and boil it down, I think the first key takeaway is simply recognizing that cardiomyopathies are a really diverse group of heart muscle diseases. They are fundamentally distinct from the more commonly discussed issues, like blocked coronary arteries or faulty valves, although they also often lead to the final common pathway of heart failure. And because they are diverse, they require specific, often nuanced diagnostic approaches tailored to their unique characteristics rather than just lumping everyone with a weak heart into one basket.
Right, specificity matters. And it certainly sounds like genetics plays a far bigger role across the board in these conditions than many might realize.
Oh, absolutely. That's the second major takeaway. Genetic factors are profoundly significant, not just in the classically inherited conditions like familial DCM and ARVC, but potentially playing subtle roles, maybe as risk modifiers, in others like PPCM, or even perhaps influencing susceptibility to Takotsubo. And the implication of this is huge. It means that family screening and genetic counseling are becoming paramount, not just for diagnosis, but for early detection in relatives and implementing preventative strategies. We're really moving towards a more genetics first approach in cardiology where understanding inherited risk before symptoms even appear becomes increasingly important.
Proactive and preventative. And the third big theme seems to be the surprising power of lifestyle and acute stress. The idea that these can have such a direct and sometimes reversible impact on the heart muscle itself is quite striking.
Precisely. That's the third key point. Conditions like Takotsubo, the broken heart syndrome, and alcoholic cardiomyopathy serve as powerful, dramatic examples of the direct and sometimes completely reversible impact that extreme emotional stress or chronic alcohol abuse can have on the heart muscle. Understanding these clear links offers tangible pathways for recovery, often centered on lifestyle changes like stress management or alcohol abstinence, combined with supportive medical care. It really reinforces the heart's incredible, often underestimated capacity for healing when the specific stressors or toxins are identified and removed.
So, thinking about all this,
Yeah.
what does it all mean for you, our listener, to maybe mull over after this conversation?
Well, perhaps this raises an important question for everyone listening. Considering the profound and often silent ways that our lifestyle choices, our unique genetic predispositions, and even our emotional well being can impact the very core of our existence, our heart, how might a deeper understanding of these connections empower you to advocate more effectively? To advocate for more personalized, more proactive, and more preventative approaches in your own health journey, or perhaps for those you care about, it's really about harnessing this knowledge to transform how we think about and manage heart health, moving beyond just reacting to problems after they occur.
All right, fantastic discussion. Now, time to test your knowledge. Here are 10 questions based on today's deep dive. Feel free to pause the audio after each question to think about your answer. Then we'll reveal the correct one and give a brief explanation. Ready?
Let's do it.
MCQ 1. Which protein is most commonly associated with genetic dilated cardiomyopathy? A. Myosin. B. Actin. C. Titin. D. Troponin. MCQ 2. Which type of genetic inheritance is most common in familial DCM, leading to a 50% chance of offspring inheriting the mutation? A. Autosomal recessive. B. Autosomal dominant. C. X-linked. D. Mitochondrial. MCQ 3. The classic epsilon wave on an ECG, while specific to ARVC, is considered what in terms of its diagnostic utility? A. Highly sensitive. B. Highly specific but insensitive. C. Both sensitive and specific. D. Neither sensitive nor specific. MCQ 4. Which of the following conditions might mimic ARVC on imaging but is distinguished by the presence of granulomas, though often difficult to find on biopsy? A. Idiopathic RV outflow tract VT. B. Hypertrophic cardiomyopathy. C. Cardiac sarcoidosis. D. Myocarditis. MCQ 5. Which age and gender group is most significantly more likely to experience Takotsubo cardiomyopathy? A. Men under 50. B. Men over 55. C. Men over 55. D. Women under 50. MCQ 6. In tachycardia-induced cardiomyopathy, which factor is considered more critical for myocardial dysfunction? The duration of the arrhythmia or the heart rate itself? A. Heart rate. B. Duration of the arrhythmia. C. Both equally. D. Neither are critical. MCQ 7. Which genetic variant is frequently identified in women with peripartum cardiomyopathy, suggesting a link to general dilated cardiomyopathy? A. LMNA truncating variants. B. DSP frame shift variants. C. PKP2 truncating variants. D. TTN truncating variants. MCQ 8. What is typically the earliest echocardiographic abnormality seen in heavy alcohol drinkers, often present even in asymptomatic patients? A. Global systolic dysfunction. B. Mitral regurgitation. C. Diastolic dysfunction. D. LV hypertrophy. MCQ 9. Which of the following is considered the most critical first step in the management of alcoholic cardiomyopathy? A. Beta blocker therapy. B, diuretic therapy. C, catheter ablation. D, abstinence from alcohol drinking. MCQ 10. In alcoholic cardiomyopathy, what is the potential time frame for normalization of the ejection fraction after complete abstinence from alcohol? A, 1 month. B, 3 months. C, 6 months. D, 1 year. Okay, pencils down. Let's see how you did.
All right, MCQ 1 answer, C, titin. As we discussed, truncating variants in the giant scaffolding protein titin, TTN, are the most common single genetic association identified so far, accounting for a significant portion, maybe 10–20%, of genetic dilated cardiomyopathy cases. MCQ2 answer, B, autosomal dominant. Most cases of familial DCM that run in families are transmitted via autosomal dominant inheritance. This means if a parent has the mutation, each child has that 50% chance of inheriting the variant. MCQ3 answer, B, highly specific but insensitive. Remember, the epsilon wave is a classic ECG sign of ARVC. If it's present, it strongly suggests ARVC, highly specific. But it's often absent even when ARVC is present, insensitive, so you can't rule out ARVC just because you don't see it. MCQ4 answer, C, cardiac sarcoidosis. Cardiac sarcoidosis, the inflammatory condition, can mimic ARVC morphologically on imaging. While it's characterized pathologically by granulomas, these are often patchy and difficult to find on endomyocardial biopsy, which can lead to confusion with the extensive fibrosis seen in ARVC. MCQ5 answer, B, women over 55. Postmenopausal women, those over 55 years old, are significantly more likely, about 5 times more likely to experience Takotsubo compared to younger women. And women overall are about 10 times more likely than men. MCQ6 answer, duration of the arrhythmia. Studies suggest that the prolonged duration of the rapid heart rhythm, more than the exact peak heart rate itself, seems to be the more critical factor in causing the myocardial dysfunction seen in tachycardia-induced cardiomyopathy. It's the relentless nature of the fast rate. MCQ7 answer, D, TTN truncating variants. Similar to what's found in general DCM cohorts, truncating variants in the titin gene, PTN, are identified in a notable percentage, around 15% of women presenting with PPCM, suggesting shared genetic risk factors and underlining the idea that PPCM is often DCM unmasked by pregnancy. MCQ8 answer, C, diastolic dysfunction. Often the earliest echocardiographic abnormality detected in chronic heavy alcohol drinkers, sometimes even before they have symptoms or a drop in ejection fraction, is diastolic dysfunction, impaired relaxation, and filling of the left ventricle. MCQ9 answer, D, abstinence from alcohol drinking. While medications are important for managing heart failure symptoms, the absolute most critical and effective first step in managing alcoholic cardiomyopathy, the one that offers the potential for significant recovery, is complete abstinence from alcohol drinking. MCQ 10 answer, D, 1 year. Remarkably, studies have shown that patients with alcoholic cardiomyopathy who completely stop drinking alcohol may see normalization of their ejection fraction back to normal heart function in as little as 1 year, sometimes sooner, demonstrating the heart's amazing potential for recovery once the toxin is removed.
Fantastic. What a deep dive indeed. We've uncovered so much today about the heart's remarkable resilience, but also its hidden vulnerabilities and the often surprising factors that can impact its health so profoundly. We really hope this exploration has given you a clearer, more nuanced understanding of these different cardiomyopathies and the incredible science behind diagnosing and managing them effectively.
It's certainly been a privilege to connect the dots on such vital information today, and hopefully to highlight how understanding the why behind these conditions, the genetics, the triggers, the mechanisms, can truly empower patients and their families to seek the right care and make informed decisions about their heart health journey.
Absolutely. Thank you so much for joining us on this deep dive. If you enjoyed this conversation and want to continue your journey into being truly well-informed across a wide range of subjects, remember to check out London Heartbeats Z Academy, UK, for their extensive educational resources. And of course, don't forget to subscribe to our show, The Deep Dive, wherever you get your audio, so you don't miss our future explorations into fascinating topics. Until next time, keep digging for knowledge.